All right, we're back. I'm Jason again. We're going to do our next panel called Virtual Impact, How Telehealth Changes the Future of Emergency Medicine. With me, I have three panelists, who I'm going to introduce right now. The first is Emily Hayden. She's out of a little place you might have heard of called Harvard. She's the director of telemedicine there at Mass General, and she's just a monster in the field of telemedicine. I'm lucky to know her from her work at SAEM, the Society for Academic Emergency Medicine, where she basically formed the telemedicine interest group. And last year, she organized and put together this great consensus conference for telemedicine. And it's just kind of given us a roadmap for the field. So it's great to have her here. Thank you, Emily. Next is Aditi Joshi. She is the creator of Jeff Connect, which is Thomas Jefferson University's hospital's telemedicine solution. And she's been able to somehow navigate the intersection of academics and industry and still create some kind of harmony there. So that's very impressive. And she's the current chair of the ACEP telemedicine section. And we have Bisan Salhi, who she's a little bit of an overachiever. She is an emergency medicine physician, but also has a PhD in medical anthropology. And with these tools, she's combined them into really like kind of being a warrior against health disparities. And that's why she's here to talk to us. And she also has a great deal of experience in telemedicine as well. The fourth panelist that I had, he just texted me, unfortunately, Shayan Vyas. He is the VP and medical director at Teladoc. He had a family emergency and he has to fly to Houston, so he's not going to be able to join us today, unfortunately. So I'm sorry that he is not going to be here. I did want to mention that this group, the telemedicine group, is the only group that had 100% participation in the pre-recorded videos, which I encourage you to still watch. Those are still going to be up. They put a lot of great effort and time into creating these talks for you guys, and I think they're great. They're really informative. So I encourage you to go watch them. You can keep watching them afterwards. Eventually, we're going to make them available for the public to watch too. So let's see. Oh, I did want to say one thing. So Dr. Zain in his talk, he said he really didn't like the term telemedicine. I don't love it, right? I don't love it, but I like it because we all know what it is, right? And so that's really what words are, right? We just have to have words that describe something that everybody knows what we're talking about. And I think it's accepted now. So we're going to have to keep using telemedicine and telehealth until a better word comes along that we all agree on that means what we want it to mean, right? Telemedicine isn't new. As Dr. Hayden mentioned in her talk, people have been doing some kind of telemedicine in some form, for 40 years or something like that. The American Telemedicine Association, that's been around for 20 years. So people have been thinking about this medium as a way to communicate with patients for a long, long, long time. It was only recently, though, like 2019, there were some polls out that said only 15% of patients had thought about telemedicine or wanted to use it. Similar numbers for physicians. Physicians weren't very interested in using it either. Then along comes this great potentiator, COVID, coronavirus, and now everybody's using it. I know personally in our institution, we were at that 15% mark of telemedicine visits, and now we're at 80, 90% for outpatient visits, which is crazy, right? So I think there's probably been a similar explosion around the nation, and we've come a long way. But with that in mind, we've got a long way to go. And I wanted to bring this group together to talk about some other people's ideas of where telemedicine is going or where virtual health is going. And with that, we'll start with some questions. I think the first question I had was for Dr. Hayden, really. Research. Has there been enough research done, do you think, in the field of telemedicine to legitimize it in enough people's eyes to say, okay, this is a bona fide system that we should all be using? And if yes, tell me what you think it is. If not, what else do we need to do?
So thanks, Jason. It's a great question. I think that I would I personally believe that it would be wrong to say we have enough evidence to say that we should be doing telehealth or virtual care or care outside of our ED bricks and mortar using telecommunication technology. We need more evidence, but it doesn't mean that we need to wait for all of the evidence to not start doing telehealth. So as you had mentioned earlier, that we were doing, sorry if I have feedback on mine, I'm trying not to. We've been trying to do, what'd you say?
You sound great over here.
Okay, perfect. It just sounds like feedback here. I apologize. And so, yeah, so we led the telehealth consensus conference. We had been planning it for 3 years and didn't realize it was going to happen during a pandemic when all of a sudden more than the 15% of people thought telehealth might be a good idea. And so we came up with 24 priority areas in research, a lot of questions that still need to be answered. Some of them along the lines of what should the competencies for emergency medicine and telehealth, and how do we say we have a competent provider in this? What about the question of how does telehealth increase or decrease the disparities in care? How do we determine if telehealth should be, if we should be comparing telehealth to in-person care, or what times we should be comparing telehealth to no care? So there's a lot that still needs to be done, but that doesn't mean we need to wait for all of the research to be done for emergency medicine to go forward and to be using telehealth. And we saw that this past year with the pandemic, of the uptake of telemedicine was astounding, but there's still a lot left to be determined, a lot of gaps in the knowledge. So.
Great, thank you. Aditi Bisan, do you have any thoughts about where we should be going in telemedicine and research?
Absolutely. So I agree with Emily. I'll just take you back a couple of years. So the ACEP Telehealth Committee, we wrote a white paper in about 2015 looking at the state of the research of telehealth at that time. And most of them were very small programs just outlining use cases. So, most of the research since then, before the pandemic, and I'll talk about the pandemic as well, but before then was really some larger programs. We did a number out of Thomas Jefferson because we had a number of programs doing it. But when the pandemic happened, if you look at the amount of research that came out using telehealth, I'll say that if you look at it, there's a couple of themes that you notice, is that most of it are looking at programs and how they created it quickly, what kind of programs can be used in various specialties, not just emergency medicine, what kind of education is going to be required, or what kind of education was done. Still a large gap in looking at the quality outcomes. How do we determine, is this really viable? How do we determine, is this going to be something we can use? There's still not a lot of research out there, partially because if you're going to do that, you really want it to be a prospective trial, and that just doesn't exist. And as far as education, there are a lot of programs outlining, hey, this is what we should do for education, but not really saying, hey, before and after the education improved. There's very few of those. So there's a lot that can be done. I mean, there's a ton of research that can be done. And this is not even going into the fact that if we consider that telehealth is really just an overarching modality, and then all of these other technologies that we may be using in digital health, such as devices, AI, machine learning, all of these apps and data that we're pulling into our EHR, into our devices, we can use telehealth and improve our visits with that type of data. The amount of validation that needs to happen with those devices and how we use it and the data needed, that's another huge gap.
Totally agree. I think that's a good point you make. Telemedicine is just another medium by which we communicate with patients, right? So it just can facilitate, sometimes, not all the time, it can facilitate a new communication pathway between us and our patients. What do you think the biggest hurdle is, though? You said, there's much to be done. What do you think is preventing us from implementing these things? Is it money? Is it like reimbursements? Is it the technology? Is it any of these other things that block us? Regulation?
Prior to the pandemic, there wasn't a lot of interest. I will tell you. So I started in 2013 practicing telemedicine. You couldn't get patients, you couldn't get doctors to do it. Not really, even though it's existed for decades, as Dr. Hayden mentioned. But saying that is like the other barriers that end up happening is that a lot of it is looking at search through a disaster lens. That's difficult because people had to scale up really quickly. And so you can look at the before and after, but because it wasn't planned out, that makes it difficult. And then as far as the devices go, or the technology itself, a lot of things, or at least like the telemedicine platforms, if they're secure, if they allow you to do video visits or have troubleshooting techniques, I will tell you, having looked at a number of them, there isn't much difference. So the platform itself, you can be fairly agnostic as long as it does what you need with the technology. And so when you're looking at trying to determine differences between them, that's not a useful question. The useful question is if you're going to implement devices, or if you're going to implement some of these things as well that do similar things, is whether or not it gives you the patient care and the information that you need. So when we want to think through those questions, I think when people design studies, they're looking at it from the way that we used to practice instead of designing research studies for the way that we're going to practice. And so that ends up being probably the biggest barrier. And to that end, what I encourage is having research with physicians as well as maybe industry. It doesn't have to be, but if you're going to do it, you really have to understand how we practice and how we think we're going to practice in the future to determine that.
And we haven't heard from you. I know a lot of your work has been looking at disparities and the equity gaps that we encounter in medicine. And to me, I think from what I've seen, telemedicine can exacerbate these gaps. The people who have great internet access and insurance and the technology, like phones or whatever, a great laptop, these people, they're already getting great care, right? And the people who don't have those are people who don't have great insurance, can get left behind. What can we do to narrow that gap or decrease the inequalities that we see?
So, you know, I'll be honest that I think that was my sort of biggest trepidation when a lot of the pandemic happened and like the scaling up of sort of telemedicine happened as well. But I think it's important to kind of realize, particularly now, like telemedicine does not have to be one thing. That there are certainly people who have, you know, ourselves all here, like have great sort of infrastructure and access and health insurance and really can kind of participate in those modalities very easily and very well. But I also think, and you know, I kind of mentioned this in the talk, is I think that it's important to kind of keep in mind that participation in sort of telehealth modalities or using them as communication and the ability to kind of have that infrastructure is really dynamic and context dependent. And so I sort of don't, you know, I don't love the binary of sort of thinking of like the haves and the have-nots from a digital perspective. I think it's really, I think the benefit of telehealth is to think about, well, what do people have and how can we be flexible in communicating with them? And so if somebody has a flip phone, we can call and text. If somebody has a smartphone, we can sort of do all these other things. If people have sort of broadband and video, you know, what can we do with them? And so I think that it's really important that we be sort of just as flexible and like in thinking kind of about, you know, the sort of like research in telehealth, there's research actually like having, you know, like telehealth and like linkage to care in rural villages in Bangladesh. And so I think if people can sort of be creative from kind of a global health perspective, there's no reason that we can't be just as flexible and creative. I think the really biggest and most important thing is to not be overly simplistic in our conceptions of patients and not to sort of like just count them out of the picture. So I think that a lot of it is going also to what Dr. Hayden said, is that just because we don't necessarily have evidence doesn't mean we can't go forward. But just because we're going forward doesn't also mean that we cannot be intentional in being equitable and flexible and really including people. So to me, like that's the biggest sort of mindset and barrier. Like,
if I'm kind of understanding you right, I think what you're saying is it's not so much the technology and not so much regulation. It's people's willingness to use these devices and use this technology and make it fit to whatever use case they're currently encountering. Does that sound like what you're saying? I think you're saying if people have the barrier there is people just being willing to accept and be flexible. Have you found that both patient side and provider side that people are accepting of this, or is it difficult to get either side to agree to use these technologies?
I think patients are overwhelmingly sort of like generally have very positive feelings towards this. Like there's certainly, and particularly patients who have either difficulties with transportation or money or kind of other structural barriers actually getting to the doctor, usually would welcome anything that would make their lives easier and more convenient. I think a bigger barrier is sort of thinking about providers, either like in them either sort of having sort of limitations and what they, like, you know, being a little bit rigid about how are the quality ways to kind of communicate with patients. That if I don't have video, I can't have a meaningful interaction or glean any information. I don't necessarily think that that's true. I think the other thing is that this is a broader stigma, and thinking that there are some people who you can communicate with better and more easily in a digital platform than others. And I think that some of it is that we have to give, like, a lot of providers sort of need to be nudged or given evidence to give people a lot of credit for being able to participate in these platforms. So that's what I hope that answers your question.
Dr. Hayden, I see you nodding along. What are your thoughts on this?
Of course, for telehealth, I'd make sure I can unmute well enough here. No, I know there's been conversations that BC and I have had before, and I think that it's just, just to highlight it, and so many times she's mentioned the consensus conference in the past of that. I think when we're developing telehealth, telemedicine, virtual care, whatever semantics we want to use, that we do need to realize that while we sort of go for the big bang of like, wow, this is so awesome that we're doing this with this technology, but that we do need to be intentional. We may have to say no to some of the whiz-bang technology because we know that that's going to close off a subset of our patients. And then also that we need to recognize, and this is where I think some of the conversations with her before is that recognize that we may have certain assumptions about which patients we think are being closed off, but actually, as she says, we need to give credit. Some of these patients actually are more able to do things than we think. So there's a thoughtfulness and I think a change of some of our assumptions that I think in emergency medicine, we've been hardened to what we think when we see a patient come into our sterile rooms of what their lives are like. But we need to be aware that give them more credit, but also recognize that you can't go for the whiz bang if you're really going to be maybe letting a lot of people down and increasing the inequities. So yeah, so I was nodding because I just remember past conversations and that I think she has such wonderful approach and wonderful ideas about this. So
thank you.
With that being said, obviously everyone has limited resources. We can't just, magically give everyone the same technology. So there's advantages to whiz bang, right? It pushes the envelope, it pushes technology, it makes people do more. And there's also advantages to, giving everyone a certain baseline level of tech and a baseline level of interaction, where if you had to, where do you put your money? Where do you put your money in whiz bang and drag everyone along by pushing the envelope? Or do you put your money in, hey, let's make sure everyone's at a certain level? Where do you think, if you had to choose, and we often do, right? Where do you put your money? Let's get all of your guys' answers for this. You want to start, Emily, since your mic's hot?
I should have muted myself, right? No, I think the great thing about it is that there's so many different peoples and so many different organizations level of risk tolerance that there's going to be some that are going to say, just like you said, whiz bang, let's do this because we know that even though we're going to be leaving some people behind, we're pushing forward the envelope. And so I think each of our institutions probably a little bit different in that. And each time it's a little bit different. And so I think so far, we've been trying to sort of push the envelope with what we can do, not with whiz bang, maybe technology, but just the workflows that we've been using. And then we also have now started pulling in the community paramedicine piece. So being able to say, well, this patient may not have access to a smartphone or an iPad to interact in our telemedicine or telehealth video calls, but yet, we can reach some of these patients using community paramedicine, bringing the specially trained paramedics out there to the patient's house, providing the tablet there, and then being able to have the telemedicine communication that way and actually do more bedside there with a patient with the paramedic bedside. So and I think that we also have been trying to decide now more with our programs when we start launching a new program is having the opportunity that if, it's app-based, but also recognizing we need to make sure that we also build in the a telephone call or as Bisan said, a text, that there has to be something that, so I think answering your question as I keep going down this, in the beginning, we were trying to go for what's sort of pushing the envelope in emergency medicine, and now what is pushing the envelope, but making sure that we are definitely not trying to shut out some of the patients on this one. So that's where we are right now. I'll let the mic to someone else, and I'll mute me now.
Aditi, we haven't heard from you for a minute. Let's see your thoughts on this. Where do you put your money if you have to choose?
I just love this question because you guys are in the Bay Area. It's such a tech question. Where do you put your money? And I will say that neither, because in the end, the whiz-bang technology, it is moving forward without anybody else, right? And so this is where we're at, is we're trying to catch up with the way that we practice medicine, what our workflows and processes are, like Dr. Hayden mentioned, because the technology is there, and we're just trying to figure out how to use it, right? So medicine does not change very quickly for a number of reasons that we're all probably familiar with. So I don't see how we're going to pragmatically say that there are not going to be any whiz-bang changes. Here at where I work, I will say this, that we try to incorporate things in sense, but this is still an academic center. So we look for the research base of it. I know you're coming from one, Dr. Hayden's coming from one, right? But Basana is too. But so how are we going to validate and use it? And then remembering too, just like everybody has said, that telehealth is not just video visits, right? It's phone calls, it's chat. All of these things can be part of virtual care and figuring out what is best for that patient. And it may require using a whiz-bang technology, right? And figuring out, can we get that to our patient? Do they have access to it? How do we use it for them? But I don't think that we should think through not allowing all of the patients to have a certain standard. We're going to get in a lot of trouble like that. We are already there. Creating that worsening disparity is only going to worsen things. And also, I just want to say that if you're going to create tech and create all of these new solutions, you really have to be intentional about it. I harp on this all the time because when we get pitched products, a lot of times we get things that we just don't want to use or can't use, and it really needs to be intentional. So that's what I'll say. Money's on neither. I'm not a gambler.
Intentionality is key, and I think that's a very good point. So we can get very excited and wrapped up in, oh, we have to use this latest new thing, but really go back and think, is it going to be an effective use of your resources, and is it going to be something that has impact on a broader scale? And I think that's very important to be intentional. Isan, what do you think? You've heard their opinions. What do you think? Where do you put your money if you have to choose?
You know, I'm also not a gambler, and I would actually agree that I think that there are a lot of people who are really, you know, like the whiz-bang technology is sort of, I agree, like a lot of it I think is going to sort of develop on its own. For me, I think what's important is to kind of echo what you said, is both being intentional, but thinking about how do we work synergistically with existing systems. So there's no reason that, you know, like telehealth is as part of emergency medicine, there's no reason why it can't be integrated into, you know, like what Dr. Hayden said, like community paramedicine or EMS units, which I think, again, sort of for me has the flexibility to, you know, think about like urban rural disparities, to think about, you know, patients who can't necessarily like come to the hospital, but also is useful if you're kind of going out to also like affluent communities, right? Like to actually like really like bridge care and improve communication. So to me, like it's also important to think about, well, what have we already done? And how can we make it better? How can this be a layered piece rather than a disparate piece of like just things kind of working independently, and we're not getting the most bang for our buck for what we're already doing?
I like bang for the buck is key. I think one of my colleagues, she's actually doing tele-ultrasound. So her idea is to have people in a remote setting be able to put on an ultrasound probe, and she's helping them guide the imaging from locally here. And I think it's a great idea and a great, you know, example of the use of telemedicine and technology that we have available now. So with this, we have a few minutes left. I wanted to ask you guys, what do you think the future of telemedicine holds? I think people are trying to explore new uses. COVID has changed things and accelerated things. Do you guys think when we're back to normal, I got my 2 doses, Pfizer, are we gonna revert back to old modalities? Are we just gonna go back to what we're used to? Or do you think people are gonna continue to push the envelope in telemedicine even when there's not that same impetus that we had with coronavirus? Anybody can speak.
Sure.
Sure.
I'll start. It's absolutely here to stay. There's no question, because now we've understand its use case. So, you know, I harken back to when I first started, you couldn't get doctors or patients to use it, and now everybody's tried it out. So the recognition of telemedicine, how it can be used, and at least some familiarity with it is going to change how we practice. What's going to have to happen, though, is just determining, what does that mean? What does that mean for our education, right? So do we start in medical school? Do we start in residency? What is the scope of practice for the emergency department, for emergency physicians? You know, if we're starting with triage at home, you know, EMS, paramedic, community paramedicine, like we're talking about earlier, Drs. Hayden and Salhi, and then obviously our in-person care, and then post-ED visits and remote monitoring. Is that going to be the next scope of practice, and how do we get there? How do we ensure that we do it safely? How do we ensure that we're trained to do it? What does that mean for us as you know, being that type of specialty that is really involved in the community? That's kind of the beauty of emergency medicine, right? We are really involved in the community, because when things fall apart, they come to us. And so we recognize some of these. And so because we recognize a lot of that, we have a tremendous opportunity to change it using virtual care and determining, how is it that this is going to be a safe practice for us, and what does that mean for us? I will say that, of course, so at the Consensus Conference, I was actually on the workforce group, and there's going to be a lot of unintended consequences for our workforce, because if people are going to be doing more virtual care, what does that actually mean for the emergency physician? So we have to think through our scope of practice, and does it mean that we're not going to be in the ERs anymore, so that we still have a type of practice for the amount of emergency physicians out there? It's going to be creative, and it's going to be exciting.
Definitely big changes, especially for our specialty specifically, right? Emily, do you want to chime
Yeah,
in?
no, so telehealth, I also agree. It's here to stay. Patients have tasted it, providers have experienced it, and there's been good and bad, but I don't think we're going to go back to normal, pre-pandemic normal, I would say. I think we need to be aware of a couple of things. When I start thinking through what are the opportunities for telehealth for emergency medicine, I start thinking about, you know, where in workflows throughout the healthcare system is there somewhere where a patient's being told, call 911, or go to the ED. And so there's somewhere there that we might be able to use the tool of telehealth to still help care for those patients, but they may not have to come into our physical emergency department. And that brings in this piece that we really truly have to, as a specialty, start to go outside, out in front of, what one of my colleagues said once, out in front of the triage desk. We are used to being behind the triage desk. We're used to the in-person care. We're used to all of the systems that have been set up for us to do as smooth of care as possible. The auxiliary staff, the EHRs, everything's been created for the in-person. But it's time for us to go outside of our bricks and mortar ED, and we are doing that with telehealth. But then we also have to recognize too that everybody else in other specialties have also realized that telehealth is available and feasible and reachable now because of the pandemic. And so there is a piece of this decreased of our ED volumes, the decreased volumes that we're seeing in the emergency departments nationwide. I think part of this is that there are other specialties and primary care practices that have said, wow, well, we can actually do this and we can spare. Like, we keep hearing from the emergency departments, don't send your patients in. We're overcrowded. And guess what? They listened. And so they have other systems being set up to help out with this acute unscheduled care that we as emergency medicine, we are so skilled at that. We're skilled at that, and we expect patients to come into us for that. Well, now it's time for us to really think about, how do we go out there, and how do we use our well-honed skill set of acute unscheduled care and use the tools of telehealth to help these patients too. So I think it's here to stay. I think it's going to be ubiquitous. I think there's a lot of opportunities out there. But I do think there's going to be a pull back to that first thing. Are we going to go back to normal? There is going to be a pull to go back to status quo. But I think there's enough momentum that and I think part of the momentum that, you know, we need to find some diversified areas of revenue in the emergency department, that telehealth will be here. And so I'm excited to see what happens with it. And I'm excited. I see so many people at the audience here that is already doing this too. So really excited about the future. So
I think we could probably have a whole conference just based on that last comment you made about how do we adjust our EM expectations to this new world of telemedicine. Isan, let's hear from you last and round it out for us here.
Yeah, I actually completely agree with everything that was said. I think that, as somebody who's nostalgic for normal, whatever, whatever that means now myself, I think it's important to also realize that sort of the pre-pandemic normal was not working for everybody. And so it's very easy to sort of be nostalgic about everything that we have lost, but it's also, I think, important to think about the opportunity for what can be and what we can really rectify now that everybody has seen, like, well, this can be so successful in so many different contexts, and really taking the, what we've learned from this and taking it forward. I think wanting to go back to the status quo can be, I think, really quite unfortunate for a lot of our patients who are not being sort of served well. So the other thing I would say is, and this is what Dr. Joshi said, is I think that it's really important to realize is that the introduction of telemedicine and its uptake really requires us to think not just about, well, how do we do this technology, but also, like, how do we even approach the physical exam? Because the ways that you can actually examine somebody over video, it's really quite, it's very much possible to get a good physical exam, but we have not been, I think, very systematic. And how do we teach medical students and residents how to do it? And how can we be more transparent about the physical and what we're looking for, such that patients also can kind of participate and be in the process? Not only are we caregivers, but also we are kind of increasing people's health literacy so that they can really be much more participatory in their care. So I think there's an opportunity to really democratize healthcare in a way that certainly has not been the case since I have been practicing or as a student. So I think that that's a really important opportunity to keep in mind going forward.
Absolutely. I think that's a great point. It's a bit of education, right? We have to educate our fellow providers, physicians, on what the capabilities of telemedicine are, and get them out of their box of, oh, I have to touch a patient, I have to listen to a patient, I have to do all these things to feel complete with my note. The same thing, we have to educate the patients too. And I think that's a great point you're making. I just realized there's a question that's been upvoted many times. I wanted to make sure I threw that out to you guys. So it says, early data show telehealth visits may generate more downstream in-person visits and may increase total cost of care. Are you concerned about this? And it says University of Michigan recently published on this for URIs. And I'll just leave it open to whoever wants to chime in.
I can start. So I read that study, and I'm going to tell you that's not actually the first study that showed this. There was one at RAND a couple of years ago as well that also said there was an 88% increase of utilization using telehealth for respiratory symptoms similarly. So here's what I would say is that what we don't know is whether or not, so we're saying that this utilization using telehealth is going to increase cases. The other concern, of course, is that it actually had people follow up more often than they would have. What is hard to determine with this data is whether or not you got somebody early enough that they weren't going to get sicker, right? That's hard to tell. So especially if you're worried about COVID or certain types of diseases. And that was true for the RAND study specifically, right? You don't really know what the long-term effects are. It also ties into the way that we actually pay for healthcare. Technically, going to your primary care or doing a telehealth visit is cheaper than going to the ER and possibly the urgent care, depending on your copay. So if we're going to look at increasing utilization, we want to remember that not all utilization costs the exact same. And if, as everyone keeps talking about value-based care, that ends up being really something that we invest in, this is actually going to probably save us money over time. And really, it's going to be the right thing to do. Having people being able to see it being seen at home and determine if they really need to come in for an in-person visit, or you can just have them follow up in something that may be more low cost, I think it's going to overall decrease costs in the end.
And yeah, just to add on to that one too, I think we're going to see more and more of these types of studies come out where it's this question of, is telehealth adding and increasing the actual expenditure for healthcare? And I think we need to I think we just need to keep in the back of the head, it's not the answer for all of them, but to remember that if we're trying to compare telehealth to in-person health, just like was mentioned, in-person health pre-pandemic was not perfect. And so if we're going to say, well, the status quo or the gold standard, which truly it is right now, but the gold standard is, in-person care, and now we're adding a couple of virtual care or adding maybe a couple more in-person, we have to be a little more holistic in saying, like, is this really yeah, dollars and cents, it may add more, but is it actually improving quality of care, and down the line it's saving? And so again, there will be more and more studies coming out like this, but we do need to make sure we keep that in the back of the head, that exactly what Dr. Joshi was saying, and just that our comparator is not the perfect system either. We still lag as a nation in healthcare for the global setting, so we just need to keep that in mind. So.
Ms. Ann, do you want to speak on this?
Yeah, I don't want to get on my soapbox about sort of thinking about costs, but I also think that it's not the only way. I think it's
climb up on the soapbox. Let's
I don't know. I'll get on it for a long time. So but I will just sort of say this, is that I think it's really important not to just anchor on cost. And particularly like a cost in a period of time without thinking about what is saved sort of for like in terms of like long-term patient outcomes, and also not to anchor on costs to the degree that we're actually sort of encouraging people to delay care and actually incurring costs sort of later on, and you know, having sort of worse long-term outcomes. The only other thing I would also say is that it's not clear entirely, and I think because telehealth is sort of, or telemedicine is many things. What are the processes by which this actually happens? Is it because we have people who, you know, is it, you know, because we're not sort of able to like do a physical exam in a way that we have been trained and systematic to rely on it? Is it because we're not able to sort of communicate with patients in a way that would like reassure them to care for themselves at home? Are there other barriers? So I think it's just as important, and I say this with my like bias as an anthropologist, is that it's really important to sort of think about the people aspect of this and not just sort of put a number on it thinking, well, if I get a number, then I know everything that's going on. I think it's very important to sort of think about this processually and think about, well, how is this happening? And is it in fact sort of worse, or is it something that would have happened anyway? And how can we sort of think around it?
That's an excellent point. I'm getting notices that we have to wrap things up here. Obviously, we could talk, it sounds like us four could talk for a lot longer about this topic. It's been really fun. And I think it just means that the conversation should continue offline and online.